Thanks a lot, sir. And I'll just get down to my presentation in the interest of time. I'm going to be discussing this whole concept of aberrometry and how a clinician can use it in their day-to-day clinical practices. To understand aberrometry, just a little basics, because I'm understanding there will be a lot of resident doctors here also. We need to understand what is a wavefront. So wavefront in optics, if you remember, even in our school days, that when the light travels, if you draw a point of all the points in phase, you get a wavefront. So if your parallel rays are going, then you get a plane wavefront. If you have converging rays of light, you have what is known as a spherical wavefront. So these all points of the rays are in phase. So it gives you a frame or a surface. So if you have a good parallel ray of light, you have an ideal wavefront. But if there is some problem in your optics, or your optics are irregular, or your lens is a scratch or a cataract, if your glasses are scratched, then you have an irregular wavefront where the light literally scatters off. So what are aberrations? Aberrations are refractive errors or the scatter of light. It's as simple as that. And what are aberrometers? Aberrometers are machines that measure this difference, and that's as simple as that. So again, what are the basic aberrations that we have? We have myopia, hypermetropia, and astigmatism, and that's what we've been checking for years and years. But once you take out all that noise, the next line of aberrations that turn up are known as higher order aberrations. So what are these aberrometers? They're basically super autorefractors. So they take out your basic aberration profile, basic myopia, hypermetropia, and then a little more, and that is what we need to treat or to understand. How do they work? They work on many principles, but simply speaking, they throw light and the light is reflected back. So either check the reflected light or check the thrown light. So if the light was supposed to travel a certain direction and travel back in the same, but it deviates from its path, that's an aberrated profile, and that's a very simple analogy on how they work. My talk is going to be based on one particular aberrometer, a combined system called an eye trace, but there are many aberrometers in the market that do similar profiling. So I'll just orient you in very quick brief to the main display. The aberrometer gives you aberration of the total eye. So how it does is, it's called a ray tracing aberrometry. So it throws in a ray of light in your eye and looks at its path. And it sequentially checks so many points as been shown over here. And that's the aberrometry of the whole eye. The machine also has a topography or a Placido topography. And from topography, you can find out corneal aberrations because it's a simple mathematical derivative. So now you have total aberration and corneal aberration. And if you do a simple math of subtracting corneal from total, what do we get? We get a very interesting number called internal aberrations of the eye. Now, internal aberrations is anything but the cornea. Actually, not even the cornea. It's anything but the anterior tear film. Because the tear film is the first surface which has been picked up by the topography. Anything after that is internal aberrations. But for most practical purposes, it lands up being the lens because that's the biggest optical element in the eye. So again, because you have corneal aberrations, you have corneal topography data, which is your basic topography data that all topographers give. And also it gives you things like pupil diameter and so on and so forth. Because these points are falling on the eye, you can assimilate these points and create a simulated vision. So for the first time with these machines, now we can know what the patient is seeing. Now a lot of times patients will come and say, sir, mujhe double dikh raha hai, mujhe shade dikh rahi hai, mujhe haze dikh rahi hai. We don't understand what it is. We ask them to draw, we don't understand what it is. But with the aberrometer, we can see what the patient is seeing. And for majority of the times, if I show these to the patient and ask them, ye aisa hi dikh raha hai? And the patient is like, yes, it's exactly the way I see it. One very important, very basic point is when we do any investigation, particularly optical investigations, including autorefractions and aberrometries, topographies, everything, we should do it in dim lighting conditions and not brightly lit rooms. And why? It's just to show you with an example that this is a bright room with a 2 millimeter pupil. This is the patient's point spread function, or how the point of light would spread. And this is the E chart. The moment I keep on opening up the pupil, notice how the aberrations start to manifest because the cornea is opening up. As the cornea opens up, more bad images will form. And so this is the patient's problem because most often our patients will come complaining of nighttime visual problems or dim light problems. And we check them in our brightly lit clinics, and that's where the problem happens. So it's very important. Please turn off the lights in your diagnostic room and investigate them there, and you'll end up knowing much more about them. Jumping on to real life case scenarios. So this is very common. I think all of us face it now. It's young female patient, very bad profile of a lawyer, because you know these are very tricky patients to handle. 6/6 vision, but just can't drive at night. This is how the patient looks. Mild cortical changes early for an age, but otherwise pretty much clear, lens in the eye. But this is the patient's aberrometry. Just again, I'll run you through. Cornea is absolutely fine. Lower half is cornea. It's absolutely fine. The total aberration profile of the eye shows a significant spherical aberration. Spherical aberration is a defocus, like myopia. But all of it is originating from inside the eye, internal optics. So what is this patient? This is a cataract. And this is the patient's dim light vision. Like we discussed, patient can't see anything at night. The glare from the headlights is bothering her. And this is how we check the patient in our clinics in a photopic condition or brightly lit condition. And that's where the patient is 6/6. That's where the patient has no problem. But the problem lies here at the end of the evening, at the end of the day when she can't drive. So the issue is an apparently clear lens, and that's a clinical judgment. But the solution is to find out using machines if you can actually pick up spherical aberrations, which are sometimes very difficult to pick up. The answer to this patient is a cataract surgery. You can counsel the patient with a lot of caution, as because they're younger patients. But there is now a documented evidence of a cataract in the eye, which is otherwise very difficult to clinically diagnose sometimes. And this at some point in time we used to call Zernike optimized cataracts. Dr. Rohit Shetty from Narayana Nethralaya had coined this term. Another case scenario of a patient who comes to us with a cataract and a straightforward astigmatism of about a diopter. So we suggest a toric IOL, and it's pretty straightforward, no brainer there. But the patient does not understand, because the patient says, I've never worn a cylindrical correction in my eye. Now this is the patient's profile, and notice how it is. There is a corneal astigmatism of about a diopter, which is visible here, which is nearly completely balanced by the internal astigmatism, which is most probably arising from the lens. So and these people we will see in our clinic. When you check their K readings, they have cylinders, but their refractions have no cylinders. It's because something inside the eye is cancelling off the cylinder in the entire optical system. Now, once we do a cataract surgery, this is what we are going to knock out, and all the cylinder will come out, and the patient will complain, surgical outcome, and say, you created the cylinder. Just to show you how flat wavefront is cancelled by a steeper wavefront. But this is balance of nature, and that we are going to tamper with when we do a surgery. So the patient went ahead, and suppose this patient went ahead with the toric IOL. We can also look at the post-operative outcomes and notice how corneal astigmatism is nearly completely cancelled, like Dr. Gulusa sir was showing with the Callisto when he aligned this is another way of checking it. One way is to check, it with this. The other is to look at it graphically, and even that eye trace shows so beautifully how toric IOLs are probably the best lenses in the world, because they're so forgiving, and even a 2-3 degrees of shift here and there will not make a difference. But this brings in confidence in the patient and the doctor both that it's really working. Another case with a high myopia with a cylindrical correction, we planned a toric IOL, T5 in this eye. And this was the patient's pre-operative, but this landed up to be a patient's post-operative refraction, and there was a significantly double cylinder actually in the eye, so landing up because of some problem. When we put this patient on eye trace to understand that the patient's cylinder should have gone away, but rather became more, we understood that there is an axis rotation. And because it has an inbuilt software, and it told us very clearly that if you give about a 30-degree rotation, your cylindrical numbers will change. So not only for planning, but also for post-operative outcomes, it's a great tool. Another case scenario, very common in our clinics, is keratoconus. Keratoconus causes your light to scatter because the cornea is not round and it's ovoid, and more importantly, it's conical. And it gives you a very bad aberration, probably the worst aberration that you can have, which is a coma aberration. Now, coma means the optical pathway is tilted, so something is tilted. Now, you can't correct a tilt with just a pair of glasses, and this is a classical coma that's manifesting in this patient. One of the easiest solutions to treat, you can't do a surgery for this. You can do intacs, you can do rings, but the best solution is to do a contact lens fitting. And just to understand, again, it's very simple. All senior clinicians know this. How does a contact lens work? A contact lens negates the corneal surface as the first refracting surface of the eye. And between the contact lens and the cornea, there's fluid. So your refractive index shifts to the anterior surface of the lens. And now the lens is round, it's spherical, it's spheric. And so the anterior surface becomes the first refracting surface, which is your lens, and thereby you have a perfect optical system. And a lot of people who are using contact lenses will swear by the optical outcomes of a contact lens over any surgery, because this is what it does. And it's very simple. You can do it even with your own hand using older machines, but this tells you that the point spread function changes and the patients are extremely comfortable. Just to show you a pre-contact lens aberration profile and a post-contact lens aberration profile. There is such a striking difference visually also, and sometimes when you try these stock contact lenses which do not have the patient's refractive power of myopia or hypermetropia, just showing them that this is what will happen when we give you a custom lens is enough to convert these patients to adopt these technologies. And this is just to show you pre-contact lens Snellens and a post-contact lens Snellens, and what a stark difference there is in their outcomes. So I'm just going to wind up with just one last case. I'm just going to move out of this case to show you how sometimes unhappy patients should be checked with these machines most often to understand what is going wrong. So this is a patient, has a multifocal lens, extremely bitter about the surgery, that is the lens that's causing the problem, and has come to us for a second opinion. This is the patient's profile. Now, just like I showed you, cornea has some cylinder and all that is okay, but there is a significant coma which is coming in from the internal optics of the eye. Now, coma means the lens is tilted. So I know even without seeing the patient clinically that the lens is not in its place. And when we dilated the patient, sure enough, you notice over here that one part of the lens and one haptic is inside the capsular bag, and one part of the lens is lying in the in the sulcus space. So it's a tilted positioning of the entire lens, and that is what is causing the problem at the end of the day. We did a UBM, and notice how the UBM shows a tilt over there. It's a very visible, very striking tilt. Just to show you a recap, what does a tilt do? It's the entire optical system is tilted, and if you look at the eye on the whole, whenever light strikes, one part will be a little more bent than the other just because different optical paths for different lights. All we had to do was dissect out this lens and push it from the sulcus right into the capsular bag, and that solved the problem for us, and the patient was happy. So it was not a problem of the lens, it was the problem of the surgery, and we picked it up. We would have thought, kya farak pad raha hai, adha rakha hua hai, the lens is the problem, but that's not the case. When we look at it from an optical point of view, we do realize that it's all these things will matter, but sometimes the only way to see it is using these machines. So if you have access to it, it's really good. If one doesn't, it's always good to take help from colleagues and use these machines, because you'll be surprised at what all comes out of these. Thank you.